You'll see this patient in your clinic. Slight anterior head carriage, increased cervical lordosis and thoracic kyphosis, elevated and protracted shoulders, and winging of the scapula bilaterally. You'll see this patient a lot, especially because patients have more of a sedentary lifestyle. Clinically, this is known as upper cross syndrome. The clinical concept of upper cross syndrome was originally developed by Czech physician Vladimir Janda. Through his observations of patients with neurological disorders and chronic musculoskeletal pain, concluded that the muscular response to joint dysfunction is very similar to the muscle pattern found in upper and lower motor neuron lesions. Janda noticed that tightness or spasticity of a muscle is the primary reaction to joint dysfunction, with weakness of the antagonistic muscle occurring as reciprocal inhibition of the tight agonist. Janda identified 3 regions of the body that experience this type of muscle imbalance pattern as a result of joint dysfunction: upper crossed, lower crossed, and layer syndromes. Today we'll be focusing on the cause of the muscle imbalances by more closely investigating upper cross syndrome. In Janda's model of upper cross syndrome, there's weakness noted in the deep cervical neck flexors as well as weak lower and middle traps. There's tightness noted in the upper traps, levator scapula, and the pec major and minor. In this pattern of imbalance, joint dysfunctions are often noted at COC1, C4-5, in the CT junction, at the T4 to 5 segments, and in the glenohumeral joint. There are several different ways to create muscle tension in the body. You can create muscle tension structurally or functionally. Structurally doesn't really concern upper cross syndrome. Functionally, it can be caused by 3 big categories: adaptive conditions, neuroflexive properties, or muscle weakness. Within the viscoelastic properties or adaptive conditions, you see that shortened muscles stay short. In neuroflexive properties or the contractile properties of the muscle, you'll see things such as limbic system activation, TRPS, or muscle spasm as a result of joint dysfunction. Muscle weakness is really where we're interested in terms of upper cross syndrome. Muscle weakness as a result of reciprocal inhibition is what really causes upper cross syndrome. This is when a muscle is inhibited reflexively, and we'll get into this more in the next section. Cross syndromes are a dysfunction of the reciprocal inhibition system. Normal inhibition system works when you try to flex your arm at the elbow. In order to do this efficiently, the biceps must contract and the triceps must relax for the joint to move in the desired direction. The tricep knows to relax when the bicep contracts due to an increase in tension in the biceps, which is the triceps antagonist, which activates the muscle spindles within the agonist muscle. Muscle spindles act to monitor both the length and tension of muscles. In order to extend the elbow, the triceps, which is the agonist muscle in this pairing, must turn on, activating its muscle spindles. The biceps, which is the antagonist in this situation, is then turned off in order for the elbow to reach full extension. Reciprocal inhibition is a spinal reflex that starts with proprioceptive input from the muscle being sent to the spinal cord via the afferent nerve. In the spinal cord, the afferent nerve synapses onto 2 neuron pools within the spinal cord. Firstly, it synapses onto an inhibitory interneuron, which then synapses onto the motor neuron pool for the antagonist muscle group to inhibit its contraction. Secondly, it synapses onto the motor neuron pool for the same antagonist muscle, causing it to fire and prevent further stretch and damage to the muscle. There was an interesting study conducted in 2016 in which 200 undergrad students were recruited from a university in Korea for a study about upper cross syndrome and head proprioception. The researchers first took photos of the lateral head and neck of each participant and graded their degree of anterior head carriage. 0 to 1 centimeters from the lateral center line to the shoulder and ear were classified as normal, 1 to 2.5 forward was mild, and 2 to 2.5 centimeters forward was classified as moderate upper cross syndrome. They had 20 students to fall into each category. These participants were then tested in regards to their proprioceptive abilities. The subject's head was moved 30 degrees into extension. It's instructed to hold the position. They then asked the subject to move back to neutral and repeat this angle 3 times on their own. This was repeated with flexion, right and left lateral flexion, and right and left rotation. Interestingly, it was found that the subjects with greater deviation from the lateral center line of the head and neck complex, aka a greater anterior head carriage, had worse proprioceptive abilities. This really illustrates in our situation that with the chronically turned on muscle spindles, which are the proprioceptive organs of each muscle, and antagonist muscle, there is a significant change in the information that is being sent to the CNS regarding position sense. As we can see, upper cross syndrome is a muscular imbalance pattern that is commonly seen in clinical settings and has become increasingly popular as people become more sedentary in their lives. As a clinician, it is very important to understand the neurological basis of this condition, as it will help to inform treatment and help to ensure better outcomes for all of your patients.